Thank you for joining us for today's Fracture Prevention Central webinar, FLS Databases, Creating an IT Tool to Support Your FLS. I'm Debbie Saldo, Executive Director of the National Bone Health Alliance. For those of you who do not know NBHA, we are a private-public partnership that brings together the resources and expertise of our 55 organizational members to increase overall health and quality of life for all by enhancing bone health. We work with our members to drive change and innovation to drive bone health by improving provider ability to align care with quality and health system incentives, education and outreach, developing and leveraging data, and engaging partners on programs to drive meaningful change. We offer Fracture Prevention Central as a one-stop shop for fracture liaison service education and implementation with a wide array of tools and resources, including a return on investment calculator, business cases, brochures, checklists, and a whole database full of webinars. These webinars, including the one today, will be available on Fracture Prevention Central as well as on NBHA's YouTube page. We also offer one-on-one FLS consult service where you can go onto Fracture Prevention Central and sign in. It will ask you some questions so that we can really get to the bottom of what your question is and can match you with the appropriate expert. Before we jump into the webinar, I just wanted to let you know that you are all in listen-only mode. We will have time for Q&A at the end of the webinar, but you do not need to wait to the end of the webinar to ask your questions. You can type them into the GoToWebinar panel, and we'll make sure that they get to our two presenters today. And now I am so excited to introduce our two speakers, Dr. Stephen Ng and Nate Rogers, both of Ohio State University Wexner Medical Center. And I will now turn it over to Dr. Ng. Sorry, Dr. Ng, we cannot hear you. I'm not sure if you're muted.
Oh, thanks. I had my finger on the mute button. Thanks, Debbie. Debbie was invited to our CME event in December, a couple of months ago, when we focused on FLS programs, and she's now reciprocating and having us do this in reverse in this venue. The topic of today is on creating an IT tool that can help support your fracture liaison service program. My first slide is a slide that shows just to remind us the patient population who we are serving, and a patient population at risk for fracture. Here's a person who's got one after another fracture, and we're trying to stop this downward cycle, hopefully through development of and implementation of FLS programs. My outline today is to just briefly discuss the osteoporosis care gap and fracture liaison services, introduce an idea of continuous quality improvement through this PDSA cycle approach, sharing our story of developing an FLS program here at Ohio State, and then I'm going to turn it to Nate to discuss the development of the actual tool itself and some of its nuts and bolts. So I think many are familiar with this slide from Dan Solomon's group, showing how after the occurrence of a hip fracture, medication use to prevent another fracture, treatment of osteoporosis wasn't so great to begin with in 2002 at 40%. However, over the next approximate decade, that number has halved to 21% by 2011, the so-called osteoporosis care gap. This is a slide that Mike Lewicki has lent me. He shared this at ASBMR a couple of years ago. And shown at the top is the hip fracture rate in the United States over various years. And you can appreciate that with time, the hip fracture rate was declining, but then hit a plateau point. This dotted line represents what would have been the expected continued decrease in hip fracture rates over time. And he's noting 14,000 additional hip fractures per year between these expected versus actual. And part of that is related to the fact that osteoporosis diagnosis has been on the decline over time, and that may be related to decreases over time in DEXA testing, but it also relates to the decrease in osteoporosis medication after fracture. Fractures beget more fractures. This is Medicare data from I think the year is 2009 or so. They took a group of Medicare recipients who had fractured and followed them the year following that index fracture. And so if you had a hip fracture, your chance, the number per 100,000 for a hip fracture, a second hip fracture, is listed here. But it's not just a hip fracture that leads to another fracture. The incident fracture could have been a shoulder or a wrist, shown here. If you recall from the prior slide that the actual numbers of hip fractures per 100,000 are in the 900, 800, 700 per 100,000 range, and clearly these are almost an order of magnitude higher. So fractures beget more fractures. To further the point that there's a time relationship, the risk of the second fracture is highest in the first year following the index fracture. This is a different paper, but the first year after fracture, the absolute risk is higher than what it plateaus at 3 to 4 years later. So to try to address these care gaps, we've got this notion of a fracture liaison service. There are 5 sort of essential components to this care coordination pathway. The first bullet includes identifying the patients who fracture, and this is actually the focus of today's webinar. How do we actually identify that patient? The FLS program then assesses for fracture risk with clinical risks, DEXA scanning, assesses for secondary factors and causes of osteoporosis, prescribes osteoporosis medications as appropriate, monitors that adherence, and monitors for ongoing fracture risk. This program is typically coordinated by a nurse practitioner, and importantly, it is a program that is distinct from the services that occur immediately post-fracture for that fracture itself. The FLS programs, secondary fracture prevention programs, are supported by clinical practice guidelines, and here are a number of groups that have endorsed development and implementation of FLS programs. 2 flagship groups that have shown the way forward include this one first by Kaiser. Rick Dell's data shown here. In this approximate decade, they've shown that their FLS program has led to a 38% reduction in the actual numbers of hip fractures compared to what was expected. in that 9-10 year period. The other vanguard group with FLS in the United States is the Geisinger Health System, and they've shown that their program has led to almost $8 million in cost savings over a 5-year period. That's well and good for these two systems, which are closed systems, where the insurance company and the medical provider community are all under the same system. But where I am, and probably where most of you are, we live in an open medical system. And in this system, as you well know, there is plenty of fragmentation of care. Best practices for long-term interest of the patients are not necessarily organized and not necessarily incentivized to get to that goal. And there are limited resources to develop an FLS program in many places. There are other provider factors. The surgical provider taking care of the acute fracture is not typically in a position to be managing a chronic medical illness. And moreover, the primary care provider is juggling many different competing primary care demands, and this attention to bone health may not make it to the top of the list, even after the fracture. And from patient factors, there is many times lack of knowledge about the understanding of a fragility fracture, implying the high possibility of systemic skeletal disorder and needing attention. So I'm going to move now to a bit of our own story of secondary fracture prevention at Ohio State. In that initial period, 2010-2012, we did have a nurse practitioner-led program. We are a member of Own the Bone, and this was a nurse practitioner who inputted data into that program. However, the funding for her position ran out, and there was a time when there was no specific dedicated program for secondary fracture prevention, this 2012 to 2014 range. In the summer of 2014, a number of us started talking about this. I had conversations with orthopedic colleague, emergency medicine colleague to try to redo this FLS program. Part of this included in the fall of 2014 an arrangement with my division director, who agreed to have inpatients hospitalized for acute fracture at our hospital be seen by the inpatient endocrine consult service. And in this way, if the patient is housed, say, in orthopedics as the primary inpatient team, they're consulting endocrinology, and thereby that financial disincentive is removed. If this fragility fracture consult were done by a member of the orthopedic team, then that would all be part of that same acute care bundle. But just like orthopedics consulting cardiology or geriatrics, they would consult endocrine in this case, and that's a separate billable service. The following summer, 2015, we implemented a clinic, which was dubbed High Risk Osteoporosis Clinic, and this is entirely taken from the Geisinger model. They also have called their clinic High Rock. And this clinic was a coordinated visit between orthopedics, endocrinology, and getting a DEXA scan. We were all located in the same building on the same floor. It did make for a fairly lengthy visit to see all these separate services, but in the end, it did help to coordinate all three of these as a one-stop shop. I show this slide of a model for continuous quality improvement, plan, do, study, act, and something that if you haven't yet tried out, maybe take parts of this into your program. So for the plan part, it's important to think about who's on this team of fracture prevention. And within that team, is there going to be a dedicated champion? Although for most places that I'm aware of, it's a nurse practitioner, maybe a physician assistant who is really coordinating the program, it may be important to designate a physician as the champion. That person is going to be talking to administration and other department leadership and can help plow the way forward for implementation of that program. You want to think about which departments are involved. We decided to do this across department between surgery and medicine. There are plenty of other programs where the FLS is embedded within orthopedics, but we decided to do this across department. You should think about the location of your program. Is this a program that's going to be entirely outpatient based? Our model was sort of a hybrid with components both inpatient and outpatient, as I'll show in a moment. And within the inpatient outpatient, which services are involved? Our model of having a endocrine visit coordinated with orthopedics, and in the orthopedic space, we had to get our respective groups of administrators together to draft the appropriate memoranda of understanding so that everybody had the set of rules to go by. And that was a process that was not a short process at our place. It took a few months. Secondly, setting goals. It'll be important to create a sustainable business plan. NBHA's got a whole platform dedicated to this on a return on investment calculator that they've rolled out, and so there's plenty of resources to tap into if you haven't already, to look at how to design this on paper when you're going to show this to your administrator as a startup program at your site. And importantly, who's the patient population? This for the slides I've created, this is my favorite one. So where does a patient with a fracture present at your hospital medical center? That fractured patient might initially present to their primary care provider versus go right away to the ED, get an x-ray right there. They may present to another facility and then get to your own hospital's ED. And that primary care provider might then instruct the patient to go to the emergency room. From the emergency room, that person is identified with a fracture and could go to the hospital, be admitted, but not all fractures are hospitalized. You might get placed in a cast or a sling or something like that and seen by the orthopedist on consult in the ED, and then arrange for outpatient follow-up. And so you can see all these various arrows and how they intersect, and I think that it's not even a complete picture. You might visualize arrows that connect to places not shown in this slide. But the FLS can receive from all these different places, and when you're thinking about your own program, where do you want that patient to come from? It can come from one or multiple places. how to identify this population of patients who have fractured. I carried a conversation with the nurse who runs the FLS program at Geisinger, and she said that she reviews on a monthly basis the list from the her emergency department of hip fractures, and she'll review it and look to see what was the mechanism, high trauma versus low trauma, and that's the basis of her identifying the list for her FLS service. Then we get to the do part. So working the list, this is going to directly feed into Nate's talk later on, and he'll show you some screenshots of how working the list might look like on paper. You want to be sure to organize your data and maintain it so that later on you can go back and measure outcomes and show how things progress, how things improve. And we want to go back and study what we just did, identify gaps in what was done, and troubleshoot, consider solutions to the problems that you identify, and set some new goals, and then take those into a new plan of action. So when we started a inpatient consult service and that first year in clinic to receive some of these patients previously seen in the inpatient setting, there was a lot of buzz about from Joint Commission about a core measure set that was potentially going to be implemented around osteoporosis associated fracture. This was first put out in 2013 and revised a few years later. And the nuts and bolts of this was to have everybody hospitalized for fracture get a basic set of labs shown here: calcium, vitamin D, CBC, renal function, liver function. It wasn't a lot. Make sure that they were going to get a DEXA scan and receive an osteoporosis drug or get into a secondary fracture prevention program. So here's our data. And remember that there was a 2-year period with this nurse practitioner-led FLS program, and then a period of time without any dedicated program called usual care here. And then the first year in for this, what we called FPP, a fracture prevention program. There were 122 subjects in the initial program who were seen by that NP in clinic. We did a sampling of the patients in the usual care time frame, and there were 149 patients that we saw in the inpatient setting in this newest era. Mean age in the early 70s, predominantly women and Caucasian. Here we're seeing maybe the results of Obamacare in action with the more medically insured patients. They were at least half overall in the orthopedic service, but a large group who were not housed primarily in orthopedics, rather medicine and a few other groups. Here's a schematic showing the fracture, site of fracture. This is mainly femur overall, but a number of others. You wouldn't typically think of radius ulna, but this might have been the person who had syncope and was admitted to our heart hospital, for example, and had orthopedics consulting on that patient. And the data, we did it a little bit better in the current era with these outcomes. So the 5 laboratory tests from that Joint Commission proposed core measure set increased. DEXA scan performance increased a little bit. Certainly starting on osteoporosis drug did, and adherence to it at 6 months also improved, especially compared to usual care. So we found that without a dedicated program, these numbers drop really precipitously. So it's important to have a program that is sustainable. But even compared to the prior era of FLS, we did quite a bit better. I don't think that this has really nurse practitioner versus physician led. I don't think that was really the point of this. But I think our program involved in a coordinated way the orthopedic group who would make lots of reminders to the patients. Hey, you should go to that post-fracture clinic. That's very important to do. So there were these touch points to give that message to the patient. I think that did help with the show rate to clinic, but not entirely. I've added this final column. So what we just saw was the 72 subjects who got to clinic, but the full set was 149. So this is a 48% transition rate of the patients seen on the inpatient setting who made it to clinic. And just looking at the bottom row for taking medication, if you had everybody, that's about half as good as if they made it to clinic. So that led us to consider our next steps. Before I do that, so in our first year of this clinic, we identified secondary causes, some very important ones. One with multiple myeloma, one with this oncogenic osteomalacia. We identified the tumor. It turned out to be this mesenchymal tumor in the sinus, and took her to surgery, and her renal phosphate wasting went away, and her bone density improved very quickly. Another patient had a form of osteomalacia of GI source. Our treatment was phosphorus and calcitriol, and within a year, her T-scores improved 2 standard deviations, and without alendronate or some bone-specific drug. So I think that our goal is not to get to necessarily to 100%, because at least in our hands, we found some patients who had something else besides the garden variety osteoporosis. Going back to a QI project, so we took our data from our first year experience and applied for and got this Ohio State Patient Safety Advancement Grant. This was there were a number of components to this grant, but the part I want to highlight here is the creation of an IT tool to identify patients. And a key to this that Nate will talk about is it was based on placing an order for the patient to get to the post-fracture clinic. We developed the tool over a 3-month period, beta tested it over a few weeks, and then applied the tool, and then looked back over the 6-month period to see how it did. And with the patient safety grant, we were able to get other people in the medical system, from nursing to pharmacists to inpatient general medicine services, to buy into clinical practice guidelines. So here's our schema. Somebody who comes into admitted to our hospital with a fragility fracture, we're asking for the primary service to consult our inpatient team, who will then ensure that the appropriate labs and DEXA scans are ordered. And it's this consult team that is entering the order to get the patient into an outpatient pathway, CSN or HIROC. Also, if there's a high risk for falls, to get them into a falls clinic pathway. And with that, I'm going to hand this off to my dear colleague Nate Rogers, who is trained as a nurse, so he can speak the language, the medical language, but he's an awesome IT programmer, and we had a great process to try to, in short order, create this IT build and share it with you here.
Great. Yeah, thanks for the introduction. Like Dr. Ng said, my name is Nate Rogers. I work at Ohio State in the IT department. I was a nurse in a previous life, and I've turned into a bit of a nerd, very happily so. So Dr. Ng included me in this process to help him translate terms from his internal grant into a tool that we could use to understand this population and their prospective care gaps. My goal is to give folks on the phone a sense of where we started and hopefully provide you with some insights to our initial strategy. Fragility fracture patients are a very difficult population to define in technical terms, since not all fractures have discrete fragility indicators. Fragility can be determined by a number of objective clinical and lab findings, as well as subjective information, and we're not able to determine fragility etiology based on a diagnosis code alone. Typically, we define our disease-specific cohorts with ICD codes, but again, we don't have that luxury with this group. In our process, we had to respect certain limitations regarding the patients that we're allowed to focus on. Our leadership had emphasized that it wouldn't be appropriate for us to collect all fractures in a database of sorts, and that we needed to be very selective of the patients this tool is capturing. In lieu of diagnosis codes, we tied 2 data points together to determine our population. We wanted to capture patients who were discharged from the hospital and who had the HIROC referral order. Fragility fracture patients are seen in all contexts of the hospital, as Dr. Ng's favorite slide showed, with arrows bouncing all over the place. So inpatient, ED, outpatient, and kind of to Dr. Ng's point too, we tried to do a lot of work in a little bit of time. So due to some financial constraints of our initial grant, our focus was that of the inpatient population. And I'll kind of elaborate more on that. And also, before engaging me, Dr. Ng had already completed a ton of work working with other inpatient primary care services to help standardize care for these patients. Part of the standard was working on creating an order set that our providers could use at the point of care in the inpatient side. And part of that order set would tee up the outpatient order for a referral that needs to be scheduled once the patients are released from the hospital. It's a challenging population, and it requires a lot of post-acute care, coordination, and scheduling, transportation, imaging appointments. So there's a lot of things to kind of address with this population. All right. In the last slide, I mentioned an order set that is presented to providers at the point of care, and I wanted to show a little bit of this in more detail. Again, this is work that Dr. Ng had worked on prior to me being involved, and this is what the folks that are taking care of these patients in the hospital are kind of looking at when evaluating this. So it's really the first step in standardizing this care, and it's easily accessible to ordering physicians. This information could be useful to take back to your prospective organizations as you all kind of look to engage and standardize your care and workflows. I won't go into all of these into detail, but it includes several different serum and urine labs, as well as pertinent consult and referral orders. One that I do want to call out is the outpatient referral order to HIROC. So a little context to this is this outpatient referral is being ordered while the patient is sitting in a hospital bed. So a little bit more on this later. Just to continue on with that order set, it also includes an outpatient DEXA scan order along with some inpatient medications. So really crossing a lot of those contexts of care. We're trying to tee up care for the outpatient side as they're still admitted into the hospital, and there's a lot of complexities with that. So going over some goals here. Once a patient is identified with a fragility fracture, it requires several different appointments and tests to ensure they're receiving the standard of care. Upon discharge, patients are inundated with a lot of paperwork, after visits information, and may not recognize that they're supposed to take action once they're discharged to call and get these appointments scheduled. I'll go through some brief strategies of how we created a report to help the fracture liaison or care coordinator understand their population and to close the gaps where they could. Our strategy was creating a back-end data query based off of SQL It pulls data out of our electronic medical record on a daily basis and is sent to a small group of Dr. Ng's associates. And as they complete tasks and close these care gaps, the subsequent reports would show their progress. So the goals of this report were to create a tool to help understand the population, to visualize discharged patients who are not scheduled for their post-discharge referral. We need to get referred patients into the clinic to get that proper care. So we want to make sure that their DEXA scans are completed within an appropriate time frame. And lastly, we want to validate that inpatient care requirements have been met. This is kind of used as a table of contents here. So each one of these goals are going to kind of correlate with some different columns in the report here. So looking at the very first goal, goal number 1 was to create a tool to help us understand this population. We really need to answer the question of who. So who met our inclusion criteria, which, as we previously mentioned, were discharged patients who had a HIROC order. Each row in this report would represent a single patient. And I took some effort to try to obviously make this all fake information, but to translate this into things that may be more universal to other organizations. So in this report, along with some basic demographics, we're capturing an ordering and authorizing provider, along with the provider specialty who's kicking this process off. This is helpful too. OSU is a teaching hospital, so we're just to give some oversight into what specialties are using this the way we would expect. We're also capturing the dates of admission and the date of discharge, and that date of discharge is helpful when scheduling the post-discharge follow-up appointments. Goal number 2 is to help us understand where our discharged patients were in the scheduling process. So once they're discharged, we need to make sure that they're actually getting that care. The first column here is the HIROC appointment status, and it shows if the referral order has been scheduled, canceled, or no-showed. In our workflows internally, we need to make sure that the scheduled appointment is linked to the referral order, which is measured by the aptly named upcoming appointment linked to HIROC referral column. The next visit with Dr. Ng column helped us to identify an internal scheduling workflow issue where scheduling folks were making an appointment with Dr. Ng, but they didn't link it correctly back to the referral. And I'd added a green one down here that if a patient actually had scheduled and completed their HIROC appointment and our scheduling folks had connected the dots in the right way, we can kind of see that this referral has been completed. Goal number 3 was to help clarify if our HIROC population was due for a DEXA scan. DEXA scans can be a bit of a tedious process to make sure that they're scheduled and complete, and as Dr. Ng alluded to, just try to coordinate all that into the same visit when possible. They're seldom completed on an inpatient basis due to the cost, but are often ordered while they're admitted and need to be completed at some point during the discharge or once they're discharged. The first column was the DEXA ordered during inpatient admission, tells us if this was ordered perhaps from that order set that I previously showed. And the second column shows us if the DEXA scan was resulted, if we had a result listed at OSU. The third column shows us if they've had a DEXA scan complete in the last 12 months. If they have, they may not need another one. Columns 4 and 5 show if a patient has had a DEXA scan in the last 0 to 3 or 3 to 6 months after the discharge, respectively. And the last column would show the scheduling status of the DEXA scan that corresponds with that very first column, DEXA scan ordered during admit. Looking at the top row on this example, we can see that this patient had a DEXA scan ordered while the patient was admitted, and it was completed as intended. So that's fantastic. Good job, and no follow-ups are needed there. The orange row shows that a patient has an outstanding order with no scheduled plans to get this completed, and that they've not had one in the last 12 months before admission. This identifies and shows a gap that needs to be addressed. And even if a DEXA scan is ordered, is it clinically necessary? This example down in green shows that a DEXA scan was completed in a couple of months prior to the discharge. So they had an order during an admission on 1/15, but they just had a DEXA scan 2 months ago. So even though there's one ordered, is it really clinically necessary for them to have another one? So just another way to kind of look at the complexity in this care and to understand where the patient's at in their care. The last goal that I had mentioned was to ensure that inpatient requirements were being met. The remaining columns are populated based on events that occurred during the patient's hospital admission. Did they have a CBC, a calcium, LFT, renal labs, vitamin D collected during their stay? And also, are they taking any pertinent medications? Lastly, the used order set one was just kind of an indicator to ask or to see if folks are using the order set that Dr. Ng had worked on, or did they somehow piecemeal this together in a way that they made our list, but did a kind of an a la carte style. Again, any patients will be on here if they were discharged and have that hierarch order. If they use an order set, it saves them a couple of steps, but there are ways outside of that to kind of show up on this tool. So an example is on the very far right, the used order set is in orange, down here is blank. That's just an example of that. Somebody put a hierarch order in and they made our list. So that's a lot of information pretty quickly. That's really the crux of what I had to show, and I hope people can find this helpful. And at the very minimum, this may be a way generic enough that folks could take this back to their organizations and use this as kind of a conversation piece to say, this is some of the information that we need to help kind of move the needle on this population. So with that, I can pass it back to Dr. Ng to talk through some of our next steps.
Nate and I have the same slide deck, and just forwarding up to where he left off. So the patient safety grant just before we identified a care gap, which was that only half of the patients seen in the inpatient setting.
I think you need to show your screen.
How's that?
Perfect.
Yeah. So the care gap identified in that first year was that only half of the patients seen in the inpatient setting were actually making their way to the outpatient setting. And if we thought that if we could improve that transition percentage, then we would get more patients treated for underlying osteoporosis. This tool that Nate showed was a way for the coordinator to start his day to see who was just discharged and who they would need to reach out to make telephone calls and try to facilitate that transition to clinic. Some last two slides, some key takeaway points. What we just showed was our story, and what we did and the challenges that we face may not necessarily be the same ones that you might face, but hopefully in this presentation there were some commonalities and some ideas that you can take away from that can help you. I think Nate and I set up weekly or bi-weekly meetings where we would hash out ideas and work through the IT process. After the tool was made, I continued to have regular meetings with other people, notably my orthopedic colleagues on our program. So think about implementing a process of continuous QI. Think about organizing goals around who's available at your hospital medical center, and work with those groups and services that are going to routinely manage the patients with fracture. Note that, again, the patient is primarily housed on a surgery service, but if the fragility fracture consult on the inpatient side is done by a non-surgical service, that is going to be reimbursable and separate from the bundled payment. And my last slide, I already mentioned the point about having regular meetings. I find that for myself, at least, there's something about having to report to another group of people that helps you to keep moving and keeping in line with your plan. And as we did, maybe at your local institution, there's a little pot of money to go after a local grant. QI is all the rage these days in many institutions, and you might want to take this idea and apply it for a local grant at your site. Again, involve your IT staff who can help you develop tools that will make your life easier. You can imagine what Nate was showing were column headers of a very long spreadsheet, but it was really to help organize the person's day and who to work on scheduling a first visit or scheduling a DEXA scan and reaching out to the SNF or the family member where the patient was actually at. So it helped to work the list. And finally, determine the workflows and resources at your medical center, because this sort of IT tool would only work if everybody's using it in concert with each other, and the right type of consults are being made at the right time. And I think with that, I'll turn it back to Debbie.
Hey, thank you both so much. This has been incredibly educational and interesting, and we have a host of questions that reflect exactly that. So I'm going to jump right in with our remaining time. Let's see, we'll start with what can we do to expand awareness about the FLS program in emerging and developing markets where there's a sizable patient population?
Oh, wow. That is such a multifaceted kind of a question, kind of a big question. I think we were faced with that question of what was our population to begin with, and we started off with just that tip of the iceberg. It's that patient who comes in with a hip fracture or is pelvic fracture, or some other reason that they've got to be in the hospital. We can go further down on that. On the rungs of acuity to people who aren't hospitalized, but there it would involve communication with the ED department and getting into discussions with their leadership and meeting with them in groups. If you could expand this from secondary prevention to primary prevention potentially, and have those conversations with the primary care staff for primary prevention. You could even further talk to radiology and consider all these incidental fractures that may not get a whole lot of attention, and creating a pathway where that gets somehow communicated and identified, and then get back to a program. So there are lots of places where fractures prevent, and I would go back to that slide to think about where they present in one's medical center, and then who's got jurisdiction over that area to start that conversation.
Great, thank you. So the next question is, the data that is pulled every day, how is this entered into the spreadsheet?
Nate, you want to take that?
Yeah, sure. So the spreadsheet really should only be considered a read-only tool. It's going to be generated based off of things that have actually taken place in the system. So for one of the slides, for instance, did they, if they were following up on a recently discharged patient with that high rock order, and they wanted to get that scheduled, they would go and do their normal workflows in the system and schedule that. And then on the subsequent report the following day, that would have that updated. So it's not really a tool that people are going in and just typing stuff in. It's pulling it from our very discrete, tangible data from our EMR.
Great, thank you. Okay, so the next question is, can you predict fracture in 1 year for secondary and primary fracture prevention? And what is your refracture rate? Actually, I guess there's 3 questions here, so we'll start with that one. Can you predict fracture in 1 year for secondary and primary fracture prevention?
The current tool doesn't do that. I guess we could do a big chart pull and see what that looks like. But we're an open system, and even if there was a fracture after first fracture, maybe that person doesn't even show up on our EMR. So there will be some limitations in that kind of a chart review.
Okay, thank you. The next question is, what is the ability to implement your database to our Epic system here at, and they list their healthcare center?
So I think that backing up just a little bit, so we're an Epic organization as well. We'd kind of looked through a couple of different ways to go about this, and we had settled on this report more or less because of some limitations we had with the funding to pursue these things. So I think that there may be other ways to do this in Epic in some other fashions, but everything that I had shown, I think that it'd be reproducible to the extent that if you took the slides that I showed the headers on to somebody with clarity knowledge or reporting, that they should be able to kind of reproduce this in your own internal system. It's not a completely linear thing. Our orders are different, our columns may be different, and I think that if anything, it would be a good conversation piece to start to pull some of that information and kind of work with some of the leadership that Dr. Ng had mentioned at your organizations to see, what else could be missing from your perspective. So again, this has really been our starting point. But as more questions arise, that may need to be tweaked some to just kind of fit the needs.
Great, thank you. So the next question is, this person is starting up an FLS, and based on both your experiences, can you share any informational gems or lessons learned that would be really helpful so that we can learn from them as we're implementing the FLS?
I would think about who might be the physician champion, who would be on the team. I think broadly, and not just the people in your own department. Think about who to tap to get the financial data, patient data, so that you can start your return on investment calculations as a critical part of your business plan. And set up a process to have a regular meeting with a few members of the team, so that you have a time and place where you're thinking about what we just did and what we need to do next. So this is continuous QI in a nutshell.
And I could add from, I guess, a technical standpoint, with all the complexities that there are with this population, I think really hunkering down and defining what data, what questions you're trying to answer. So even if you were to kind of draw up what you would like this to look like on an Excel sheet or something like that, I think that would be a really important starting point to kind of take to your report writers and IT folks to say, here's the population defined as such. This is kind of what we're looking at, and these are the questions or the columns that we're trying to answer for each of these folks.
Okay, thank you. Can you speak a little bit of how you work with primary care and some of the ways that you've engaged them successfully?
So the workflow presented today took patients who are hospitalized. So these are patients who could have primary care within our system or outside of our system. But there's plenty of communication both from the inpatient side and the HIROC side that goes back to the primary care. And not every patient who is seen in our post-fracture clinic needs to stay there. And we can certainly transition care back to primary care for many patients. There are lots of folks who, at least in our center, are coming from quite a distance, and that itself is a barrier to coming to outpatient clinic. And we actually we should do a better job at facilitating the transfer of osteoporosis care to local resources than we are currently doing. But certainly that does include primary care.
Great, thank you. Someone is asking whether you have data on your return on investment from this FLS program.
Oh, yeah, I'm about to. So the a little bit of background. So the grant supported a few hours a week of a person in our research group who functioned as the patient navigator, the person who is going to make a lot of calls. Funding for the grant has run out, and so has a dedicated person to do that function. So I'm very quickly going to be meeting with leadership in my area to try to see what we can do about this moving forward. Hope that helps.
Thank you. So the next question is, what was the best way to move this forward with your administration?
I have a very good relationship with my division director and administrator, and we've got regular overview times where we're looking at the program and from a 10,000-foot view, looking at where we have been a year ago and where we are now, and then next steps. So, tagging on the prior question with the ROI. I am going to be presenting some numbers to my division director with a business plan to try to get more personnel support for our program in just the next few weeks.
And it looks like we have time for one last question. This question is asking specifically around patient identification and how you were able to capture so many people, how you identified where the barriers were and where you were missing patients who had fractures within your health system.
I can start with that, and Dr. Ng, you can finish it. Our leadership was very specific on we weren't allowed to create a fracture database. So we couldn't start to collect information on patients simply for the fact that we know that they had a fracture. We needed to make sure that endocrinology was on this patient's care, on their case, so to speak, involved in their care. And then that was the way that we were able to say, if they had a high rock order, endocrinology is involved and they're going to be part of this tool. So, as long as their patients discharged and that order was placed, they should be on the tool. As far as like patients that were missed, it's more of a missed opportunity, I would imagine, that if somebody had a fracture and they, should have, could have, would have put that order in, and they would have been part of this tool set in this program.
Our initial approach was to try to identify ICD-9 and then ICD-10 codes that might find this population, but as hard as we tried, we couldn't distinguish easily the fractures which were low versus high trauma. As I understand it, there's 1,000, almost 2,000 potential fracture codes at our institution. After the patient is discharged, I understand that there's a office full of people who are fine-tuning the ICD-10 codes to finally get to fracture trauma or non-trauma, but that information would be after the fact. The patient is even discharged and too late, so it's not actionable. I wish there were an easier way to do this with an ICD-10 code that distinguishes high trauma versus low trauma, that the primary teams can easily enter at the front end, and maybe we could identify the patients in that way up front. As Nate mentioned earlier, we had sort of this ethical issue about who how wide the net could be cast. The leadership did not want to set up a system which would sort of inappropriately funnel patients just to this particular clinic if other providers are managing osteoporosis. So we had to be very intentional that there was an intent for that person to go to a specific clinic. So that was the justification of patient selection identification by tagging it to a specific order.
Thank you so much. And thank you, Dr. Ng and Nate, for this wonderful webinar. We truly appreciate it. And thank you all for joining us today. We hope to see you at our next Fracture Prevention Central webinar. Have a wonderful afternoon.
Thank you.
Thank you.